mentioned before, before I was with CFA, I spent 2 years as a fellow in the Division of STD Prevention. And my background is in using very similar methods to these dynamic network models for to understand chlamydia transmission. So that's kind of how I got roped in to all of this. But huge props to my colleague Patrick, who was a fellow with me in STD prevention, and he's still there now, who had to learn a lot of these network methods kind of on the go as we joined the response. And it's not an easy lift. So props, really props to that. Yes, okay. So these are, I'm not gonna highlight everyone on this list, but just kind of the acknowledgement that none of our response work, and especially the modeling work, ever happens in a vacuum. We had to rely really heavily on, what data is available and other analytic efforts. And this was also a lot of our framing and results were really shaped by input from community outreach coordinators and subject matter experts in the field. So I think everyone is probably relatively familiar, but just as a really brief overview, Mpox, what we now call Mpox, at the beginning we referred to it as the monkeypox, but it is caused by the monkeypox virus, which is a member of the orthopox virus family. This is why we have a vaccine. The vaccine was originally developed as a kind of like second or third, I think it's probably third or fourth generation actually, version of a vaccine for smallpox, because the previous kind of like attenuated smallpox vaccine couldn't be tolerated in populations that were immunocompromised. So the United States and other groups had undergone a lot of effort to develop a vaccine that would be tolerated by those groups. And so this is why we have the vaccine that we have right now. Traditionally, Mpox has two clades and is spread in West and Central Africa, and it's endemic there, but more traditionally, it's household transmission and zoonotic transmission. So there's a rodent reservoir, and that's where people most often become infected, and they can transmit it to members of their household. And that's kind of the most common route, but in the last what we now know, that the last couple of years, there has been transmission of clade 2B, particularly, I believe, in Nigeria, but that eventually started to cause an outbreak in 2022. So this is what we saw ultimately. So all the blue dots in here are countries where Mpox is endemic and where it had spread throughout the 2022 outbreak. So I think some of the stuff I wanted to share from this is not just the work that we had done, but I think also like how work was done in the context of a government response, because I think we had a little bit of a different mindset occasionally than other like academic groups that were contributing to papers and stuff during this. So also, is my like video thing covering any of the slide, or is it all good?
No, you can see it at all.
Okay, great. Cool. So we kind of, in terms of the network modeling stuff we put together, we kind of classified them into two different categories. This is kind of a classification after the fact, but this is how it kind of ended up. So we had what I would consider more short-term, timely products that related to messaging that the response either wanted to put together, and so that we were still crafting the message and we were able to contribute to that, or it was like a combination with other comms teams. So we were able to collaborate with them in order to support their messaging. And then we also had have these other longer term, more traditional scientific products that are reflecting on the effects of policies that were implemented like while we were still kind of figuring everything out. And so I'm going to talk about three of these. The New York City paper is actually still in progress, and so I don't have a lot to share about that today. Okay, and I just also wanted to mention, and this would be more fun if Kelly was here, but that in addition to the network modeling projects that Patrick and I led, the modeling team itself did a whole lot of other work that was really, really crucial, and I think more like traditional outbreak response and stuff that we really needed in order to produce these more complex models down the road. So Kelly and others really led a big effort. This paper actually has been published. This is a screenshot of the preprint, but estimating the incubation period. And then eventually we also had some setup of regular RT forecasts. And so those were hosted on CDC's website eventually. So there was the modeling team covered a lot of stuff. So just a quick summary of the results I'm going to share about the network models. So we had our first MMWR, which effectively said that most of the mpox transmissions along the sexual network are transmitted during the one-time or like really short-term, more spontaneous encounters in the network. And so behavioral adaptations that we observed actually helped reduce and specifically reduce the rate of new spontaneous partnerships, and that had a big impact on transmission. And so that was in collaboration with other work done by a community outreach team. There's a paper that was looking at the model in DC, and we wanted to know the various roles of these behavioral adaptations and the vaccination campaign. And we'll find that the behavioral adaptation slowed the initial spread of mpox, but in order to end the outbreak as fast as we did in DC, the vaccination was really required. And then the second MMWR, we were trying to kind of do a risk assessment across a number of counties with large MSM populations and assess their immunity status, and also how that relates to the possibility that they could experience an outbreak if mpox were reintroduced. And we found that this is almost 600,000. This is just over half of all of the estimated MSM in the United States live in jurisdictions that have relatively low immunity. And then we have a couple other items in progress that I'll just mention, but not really talk about. So the modeling framework as a whole, it's built off of a agent-based dynamic network model called a STIRGM, a separable temporal exponential random graph model, which I can never say properly. But it was developed originally as a part of a co-agreement with an academic group at the University of Washington. And this was a partnership between them and the disease STD prevention. And so they were at the time looking at how PrEP guidelines was going to influence HIV transmission. And so they had developed and put up online this dynamic network model of MSM in the United States. And they were modeling HIV, so we were able to adapt it. And so it's based on these two sets of data. And so we were able to adapt it for our mpox needs. And so importantly, the STIRGM behavioral data are simply egocentric surveys, which is kind of a cool, often when you're doing network modeling, you never have a complete network in real life. And so being able to have methods where we can infer the network from survey data is really helpful. So I'm gonna skip this because I think probably we understand why non-random contact, we like networks for particularly non-random contacts. ERGMs in particular came out of a kind of two fields. One was a group of social scientists who really cared about why we form the ties we do. And so ERGMs it's a statistical framework where you can actually interpret the coefficients on all of the terms in your model as how likely you are to form ties with someone else based on other attributes. And so this could be nodal attributes like demographic attributes, if you're more likely to form partnerships with someone of the same race or age, or other attributes or like geographic areas, that sort of thing. And also control like how many ties people have, that sort of thing. And so these methods were developed for interpretation of data. And so we were cared about why we form the ties we do. And then these have been not co-opted, but also starting to use by epidemic modelers who care about the effects of the observed structure on transmissions, not just that the structures exist, but why that they are there, and because that helps us sometimes do scenario modeling to see if those, if the reasons why people form certain ties change, and to evaluate that. And so that's kind of where this came about. ERGMs we're using egocentric data, so observed data, in order to inform these networks, but they can also represent more idealized structures or be estimated from complete network data. That's kind of where everything started. So this is just kind of a little schematic of how the separable temporal, like how we get to dynamic models from these original random graph networks. And so basically we have y of t, so this is like say time t1, And we actually separate the ties that form and the ties that dissolve into two different sets of coefficient. And this is useful because sometimes not all the reasons you would form a tie with someone are going to be the reasons why you would dissolve a tie with someone, right? And so these two generative processes can be independent of each other. So we have at every time step, we have ties that form based on the egocentric data that we have fit and turned into coefficients in the network, in the model. And then we also evaluate ties that dissolve. And these can get really complicated, but the dissolution models in these networks are simply based on the average duration of each type of tie. And then we use an MCMC process to figure out how many of these changes happen per time step. And then we have our next time step of network. So this happens daily in all of the models that I'm going to show. I've talked a little bit about the data already, but in particular, the things that we are modeling are we have split everything into 3 different networks based on the type of relationship. Primarily because 1, these relationships have very different durations, and 2, because actually some of these, your like propensity to form a tie with someone of a similar age or a similar demographic group actually is different between the type of relationship that you form. And so, like, for example, main partnerships, so like long-term partnerships, we found that in the data, it's more like race mixing, for example, or like age mixing is actually a bit of a stronger effect. But for the instantaneous model, those are a bit more relaxed. You're like not less picky, but like you have like a wider set of preferences for different types of relationships. So we can model that in this framework. We also model what sexual role they prefer for anal sex. This comes out of HIV literature. In our current models, the way we've updated it, we actually include anal and oral sex because that's also important for mpox transmission. It's very like close contact as opposed to like a true sexual transmission process. And so the networks that we are using in the current response and some of the later projects I'll talk about actually are a bit denser than the ones that we use in the preliminary projects. So just as kind of an example of how we would go from survey data to estimating these networks. So this is what I'm showing you right here is a little graph of the probability that someone in the network has either 0 or 1 main partnership and 0, 1, or 2 casual partnerships. So this is what we call like a degree distribution. And then we scale these. The terms we feed into the fitting procedure are really just the counts of whatever we are interested in. So every network is going to have a density term. And so we would calculate that, for example, in the main network is simply the proportion of all of the people we would expect to be in a main partnership times our population size, which in this example is 10,000, and then divide by 2 because each of the people are in a relationship we actually have, but that's counts for 1 relationship. So we would expect to have on average just over 1,400 partnerships in this network based on the data. There are other terms we can add. Not all of them we've used in these models, but oh, geez, my thing is very sensitive today. I'm sorry. So we have an edges term, which controls the overall density. That term will be included in all of the networks. Node factor terms are kind of like activity terms. So people of a certain age or race group or whatever class, they have like activity levels that could be different than people in a different class. Node mix is kind of similar, but it's actually it's talking about the number of ties between nodes of certain classes, and as opposed to just like general activity within the class. And then we can have concurrent ties, so people who have more than one ongoing relationship. And then you can do all kinds of other stuff we have like an absolute difference term for the propensity to mix with people like similar in age to you. So this is kind of a schematic of how the workflow happens. So we have the survey data. We can either manually calculate all of the target stats, or if you have, or you can use what's called Ergem Ego, and this is a package developed to help you go from the survey data to those targets a little bit easier. Some of the manual calculations can get pretty intense, and it's a great way to introduce unforced errors into your project. But so once we have the fitted network objects, we use EpiModel and other specialized modules to govern all of the other like traditional vital dynamics and transmission processes that you would expect in a transmission network. So I just wanted to highlight one thing about all of these. So the networks themselves reproduce population level attributes. So the mean number of main contacts. So we're going to have some stochasticity around that as ties form and dissolve stochastically at every time step. But we kind of hover around the mean for all of the terms we have in each of the model. However, the individuals kind of have their own experience. So each individual can be a part of a different risk group and say like they have more one-time contacts than other people, or some people are more likely to have like more like what we would call, what is it, like monogamous partnerships consistently with not a lot of overlap. So basically like we're targeting the population level attributes, but each individual like kind of has their own experience. So we have these 3 set of overlapping networks because someone who has a main partnership can also have casual contacts, and we govern how likely you are to have other types of relationships based on your current number of relationships based on the data. And then for the first project is actually just a very simple SEIR because we didn't have a whole lot of information about the natural history of this new Mpox strain yet. So the first product we put out, this was kind of a fun one because this was I think the IM leadership didn't really know what we were able to contribute. And this is a kind of an ongoing question about like how we communicate with, I think, with leadership and what leadership knows about what we can contribute, and what the role is between like how often they're asking questions and how often like we're actually contributing. Say like, hey, I think this is really important for outbreak dynamics, that sort of thing. So it's a bit of a back and forth that we got better at as time went on. But here we had been trying to set up a model of Mpox spread. But the problem was we didn't have it was still really early on in the outbreak. And so we didn't have really good estimates of like the per contact probability of transmission or other factors. And so we ended up doing kind of an exploratory analysis that had kind of like a low transmission scenario where the probability of transmission was lower, and a higher transmission scenario. And as we were developing that, the COPE team, the community outreach team, had conducted a bit of a short survey and found that men were changing their behavior in response to this outbreak. And so we said, great, let's try and quantify how that can influence Mpox transmission. And so this was actually kind of a cool way to interact with each other. And so when they put out their paper about strategies adopted by these men to prevent Mpox transmission, we were able to say, and we think it has helped, it has slowed transmission, it has reduced the total number of cases so far until we can get vaccines into counties. And then also one of the cool things that came out of this was just based on looking at the number of transmissions by what type of relationship people were in when they were transmitting. So we were able to show that one-time partnerships accounted for like a very outsized proportion of all of the infections. So that really reinforced these behavioral adaptations that people were already conducting, and helped reinforce other messaging to say that, hey, like the best thing that you can do is to reduce your behavior in this way. So that was really helpful. The next big question we had was around both the combination of behavioral adaptations and vaccination campaigns. And so we're going to use Washington, D.C. as an example because they had a relatively early outbreak relative to other communities, but they also received a lot of vaccine really early on. So they had a really strong vaccination campaign. And so we wanted to understand the variable roles of behavior and vaccination on the outbreak. Yeah. So again, this is the framework I've shown before, but we fleshed it out a bit. So at this point, we understood that Mpox also had an asymptomatic but infectious period. And so that was inferred from other work that was done by the modeling team. And then we have also added vaccination. People can get 1 or 2 vaccinations. Over the course of the outbreak, our estimates of vaccination efficacy have changed quite a bit. So in the final papers that were published, these numbers are actually quite a bit higher. I think it's close to 70% reduction in acquisition probability for one dose, and then 80 or 90 for the second dose. So we have this, our little model orb. And so for this project, we're going to input DC vaccination campaign. And by that, we mean the number of vaccines given out by week. And we know if they're first or second doses. And also, we're going to take information about these kind of short-term community-driven behavioral adaptations. We're going to fit this model to the number of diagnosed cases weekly through May 2023, and our output is the diagnosed and undiagnosed cases under different scenarios. And so the version we fit is the one with vaccination and these behavioral adaptations, because that's what happened. And then we can do some other scenarios to say, what if we had just had the behavior change? What if we had just had the vaccination, et cetera? So figuring out how to model behavior change was actually really complicated. This is a project that Patrick led. And so we knew that we have better data now on the degree and timing of these behavioral adaptations. But at the time, all we knew essentially was that people were reducing their acquisition of new partners, and especially these like shorter one-time partnerships, by about 40%. So we knew kind of the max. But we didn't know how long it was occurring in each of the counties. And so we didn't really have a good way to go about doing this, but we settled on a approximation based on the number of, this is both on Reddit post, but we also like ran versions where we were looking at Google searches or like news articles, that sort of thing. So basically thinking about awareness of Mpox in a local community. We also tried to look at it like by community, because like the timing of the outbreak was different in various counties, but it's actually very true that even if you spread it out by geography, most of the Google media and like Reddit activity is all surrounded around the public declaration of the emergency outbreak. And so we think that kind of people were at least searching for whether or not they should be changing their behavior in accordance with kind of like national outbreak dynamics rather than their local outbreak dynamics. But in DC, their curve actually fit really like kind of mirrored the peak of or came very close to the peak of like the national level. And so we thought it was a decent approximation for at least the duration of adaptation. Basically, people are going to change their behavior really quickly over like a kind of a 2-month period, and then they're going to slowly return to their previous behavior. And so we fit the model. So in addition to, so Patrick ended up fitting the kind of like weekly change in behavioral adaptation, and he also fit the per contact transmissibility. And I believe that there was another component, because one of the things that we have struggled with in this framework is that these methods are really good for modeling endemic diseases or things where we think they're around the equilibrium, but these methods are actually pretty challenging to fit outbreak conditions, like that first steep increase, especially because there's all kinds of like ascertainment values, and there are ways in which having like such a mechanistic model actually like kind of prevents you from being able to like hit the exact slope. So in DC, we were able to do this pretty well, but this has been challenging for other projects like in New York, where the curve is actually very, very steep, and we're thinking through how to add extra infections based on travel. We think there's like multiple importations because there's lots of events during the summer, and how to kind of account for that in these models is a little bit tricky, but something we are still working on. So what he found, so this is cumulative cases. And so this bright purple curve is the vaccination and behavior change that we have observed. So this is like the fully fitted model. And then if you remove either the vaccination or the behavioral adaptations or both, so both, you'll get the black line. Red is if you only had these behavioral adaptations, and dark blue is if you only had vaccination. So we estimate that vaccination alone would have averted about 64% of all of the cases. Behavioral adaptations alone would have averted 21% out of all the cases. But these things work together, right? And so because, especially since because behavioral adaptations happened earlier than vaccines were available and like fully spread into the community, the behavioral adaptations acted earlier and they were able to slow the curve quite a bit until vaccinations were more available. But vaccinations are really crucial in ending the outbreak in DC as early as we did. We think that we estimate that DC was able to vaccinate almost 100% of their like higher activity or more at risk MSM. And so this like really contributed to the like total like susceptible depletion of the population. And so we don't think that DC's outbreak, it's one of the shortest outbreak we observed in a county in the US. We don't think they really could have done this without their very high levels of vaccination. So we also looked at kind of some what if scenarios around vaccine timing and vaccine availability. And so we find that if the vaccine timing had been earlier, so if we had had vaccines about a month earlier, we could have reduced the caseload by another 30%. But if we had delayed by another month, it would have also it would have increased by about 30%. The total availability in DC has less effect, mostly because they actually managed to saturate their high risk group really, really well. They had kind of an outsized vaccine supply relative to other counties. So they're like in giving them increased dosage wouldn't have actually helped, but it may have helped other counties. Yeah, so they got effectively like sufficient vaccines. So at the beginning of 2023, the next project we started was based on the observation that while diagnoses of Mpox were very rapidly declining, so was the rate of vaccination. And in addition to that, vaccination coverage by jurisdiction varied greatly. And so this little graph is showing coverage among what we estimate to be the at-risk population, which is based on the number of MSM who are living with an HIV diagnosis or are eligible for PrEP, not just on PrEP, but eligible because eligibility is based on certain behavioral indicators. So we see that basically there is a really wide variation by state. And so we're actually going to model by county, but the paper that this put out was by state. So we wanted to know, what if like global travel is a thing. There's still low level spread in various places. We wanted to know if Mpox cases are reintroduced into certain counties that maybe don't have them now. Is it going to cause an outbreak? And if it does, how big could the outbreak be? So we're going to use the same modeling framework, but our inputs are a little bit different. So our inputs are the distribution of immunity by activity group. This is extracted from Patrick's model. So because DC was able to vaccinate either have immunity from either vaccination or a previous infection, they're kind of like our gold standard highest level of immunity that we model. And then we slowly just kind of create scenarios where it's steadily decreased, and we're going to map counties onto these outcomes later. And so our outputs here are for each level of immunity, what is the likelihood of an outbreak? And so we're defining this as sustained transmission greater than 3 months. So we're really filtering here for not like stuttering chains. We're like trying to model like true, like larger levels of sustained transmission. And then how big do these outbreaks occur, especially particularly relative to the size of an outbreak in the county in the previous year. This is largely what I have just explained. Yeah, and so our denominator, when we say at risk, so it's MSM who were recommended to receive PrEP, MSM living with HIV, and then another like kind of fudge factor to account for partners of those people or healthcare workers or other people that might be eligible for vaccination. For the record, we didn't pick this definition, but it is useful because there are actual data on these numbers, so you can ground it in some data that is easily accessible. So these figures are not as cute because the MMWR has very strict guidelines, and it's basically you just send them an Excel spreadsheet and they make this, which is not wonderful. But basically the point here is we had been looking for a threshold, because that would have really helped policy to say, like, if you can get to certain level of herd immunity, then you're going to prevent an outbreak in your county. We don't see this for the risk of an outbreak that would last longer than 3 months. We basically just see a linear effect. More immunity is better. But we do see a little bit of a threshold when it comes to, oh, sorry. So this, for example, is Suffolk County, Massachusetts. And so we estimate that they have about 64% coverage with a 20% risk of an outbreak if Mpox is reintroduced. Whereas this is Harris County, Texas. So this is Houston area. And we estimate that they have 17% immunity and they have a 50% risk of an outbreak pending reintroduction. So there is kind of a weird threshold for the size of an outbreak. And so you'll see that the y-axis is all relative to the size of an outbreak in the previous year. So for counties with less than 25% immunity, we again see this kind of linear increase where the less total immunity you have, the greater your outbreak is going to be. There is this weird threshold period where as you increase, the size of an outbreak drops quicker than you might expect otherwise. And so this is what we kind of consider our medium risk or like threshold, where it's improving faster than if you have less than 20% or 25%. And then you have any county that got really achieved above 50% coverage. Even if they do have an outbreak, it's going to be really small relative to what they experienced before. So we consider these counties to be really protected from an outbreak that would like put a lot of pressure on the public health system, for example. We also quantified, so we listed, these are just the low immunity counties that we looked at. So we looked at 50, what's called ending the HIV epidemic counties, and these counties have been highlighted by the CDC as having, basically they account for most of the new HIV infections. So some of that is not related to MSM population. There are other HIV outbreaks, kind of endemic stuff happening in the US, often related to injection drug use, but particularly for the more urban areas or these counties that have like big cities in them, a lot of that is driven by MSM transmission. And so those are the counties that we kind of assessed for risk. And so these are all the counties that have low risk. And we found that almost more than half of all the estimated MSM in the US live in a low or medium coverage jurisdiction. So this is to indicate that while there are plenty of counties, and those counties are very large, that have sufficient coverage, that there's a decent amount of work to do and that we should still be trying to find ways for people to get vaccinated, especially as we come up on like summer pride in general, like event and festival season where you might see increased contacts. And this, and NMWR made this little graphic for us when we published it, which was cool. And so at the time that we had published it, we were also seeing Mpox cluster in Chicago, but we think that this was broadly in line with our results. So even because we are filtering for the larger outbreaks, we acknowledge that smaller outbreaks do occur, even if the risk of a large outbreak is low. So Cook County achieved pretty high coverage. And so they had a 22% risk for a sustained Mpox recurrence, but they have a higher probability of having like these small stuttering change, which is what we saw. We saw that these introduction of cases had a couple additional generations, but it kind of petered out after that. Although this cluster did introduce some questions about long-term vaccination efficacy or efficacy in immunocompromised people that I think in general we haven't really resolved yet. So there are a number of discussions and limitations, but I think one of the big points here is that we assume the same network structure across all of these counties, mostly because we do not have data to do really anything else. But one of the things I am concerned with as we like move into the future and we produce additional risk stuff for thinking about 2024 and potential clade 1 introduction is that I don't know how likely it is that the like density of a network in a big urban area is going to be the same like in San Francisco as it is in, say, Houston, where everything is a little bit more spread out. And I don't know, and it's kind of unclear how that like geographic spread influences like venues that people attend and the kind of the like accessibility of having a lot of partners or how far people are going to go to have sex. So I think that there's like some potential that we have uh, overestimated the risk in some counties that like are large, but maybe like in effect are a little bit more rural than say like DC or San Francisco or New York City. So that's something that I'm continuing to think about. As kind of a wrap up, Mpox is showing up again in the news. There have been some sustained transmission of clade 2B in the US since this outbreak, but cases have been very low. But we're seeing in DRC that one, there is a much larger outbreak of clade 1 household transmission than we would normally expect, and that's been ongoing for about a year. We also have evidence of at least 2 different outbreaks that is likely mostly sexually transmitted, which is somewhat new for clade 1. And we know that at least one of those outbreaks, it appears to be a new strain. So this new strain could be kind of analogous to the clade 2B strain that produced the global outbreak 2 years ago. So there are some concerns about that. We're working on making some updates to the model to produce new risk assessments. So some of the things that we have done to update the model. So we're using more updated data. Some of this stuff was available when we started the response. We didn't really have time to adapt brand new models and fit new networks using the data. So we have gone back and done that now. So all of our new work is all based on these new networks. We've recalibrated some of the parameters using what we now have as the gold standard data set from the previous outbreak. So that's been really helpful. We have updated, immunity coverage, except for certain counties that don't feel like they need to report to the federal government their vaccination status anymore. And we're doing it a little bit differently where previously we had one network size and we modeled different immunity thresholds on that network and kind of like linked counties to those thresholds. We're actually modeling the counties individually. So based on their estimated size of the MSM population. And we're also doing some additional work on the short-term behavioral adaptations and the timing of those, like if we think people would adapt their behavior more quickly, if an outbreak were to occur because, they've been through this, they know what to do, or if because maybe it takes longer or it's not as intense because of fatigue and or a lot of people are vaccinated, maybe they like aren't changing their behavior. There's some evidence of that in survey data. So these are all kind of the things we're thinking about. Some challenges we have faced in the response. These models in particular, I think you can get a lot of information out of them and I enjoy using them, but they are very data hungry, which is not necessarily the best strategy in a situation with like a novel pathogen. So we had to rely really heavily on Kelly and other members who were doing those like natural history estimates. We really couldn't have done all of this work without those initial analytic products. The open source software for this approach exists, but it is not easy to use. I'm deeply embedded in it, but not a lot of other people are. And quite frankly, only having 2 of us at the CDC who know how to do this is stressful. I think in a bigger picture, and I actually would be interested to hear from you guys who have also worked with, particularly government stakeholders. I think the framing of results can be really difficult. The stakeholders don't always know what the models are capable of, but they have questions they want to ask that may not be actually appropriate for a model. Or sometimes we know, sometimes like we have an idea of what to produce, but it's hard to know how results will be used to inform policy. So there's a bit of a give and take that I think can be alleviated with like constant communication, but it's still tricky and has kind of changed the IAM leadership. Over the outbreak, it was more than a year. So the leadership changed 1 or 2 times. And each time you kind of have to like get a different sense of how questions are going to be asked. So that can be a challenge. It's also not always clear if such a complex model is necessary to answer all the questions posed. I think in this case, particularly around the like, what types of relationships were really contributing to the outbreak that helped communication. But I don't think that we need this complex of a model to answer all of the questions that were posed, but we also didn't have a lot of time or staff to like compare different frameworks to do something more efficiently. And I think that's maybe something that CFA is working on. And like having just like a bigger team that has this kind of capacity is really great for that. But at the time, I think, I don't think we needed such a complex model to answer everything that we were asked during the last outbreak. Oh, that was it. That was the last slide. All right.
Awesome. Thank you. That was really, really interesting. Would you like to run your own question session, or would you like me to handle the hand?
I can run it now that I can see everyone. All right. Well, Sam, you have a question.
I do. I have quite a few, but my first one is incredibly pedantic. What do you mean by refine? In this context, like what does refine mean to you? Yeah.
I think in particular, refine in this context, as we're moving forward, uh, had to do with the way that we calibrated the per contact transmissibility parameter for clade 2B. So we're concerned about clade 1, right? But we needed to redo, because we had updated these networks, we needed to redo the calibration. And at the time before, we didn't, because different counties had different timing of the outbreak, and there were some ascertainment issues that didn't get fully corrected, but certainly having the retrospectively having this gold standard data set where we could say like by county what was going on a little bit easier was really useful. So we could go back and say, so I actually, in the process of trying to just get a new estimate for our clade 2B per contact transmissibility, I actually fit the early phase of the outbreak before we think behavioral interventions or behavioral adaptations were occurring and before vaccinations had gotten to counties. So I fit like many different counties and figured out and I was able to generate, I think, a better estimate of per contact transmissibility based on that, because a couple of the counties, particularly ones that didn't have additional confusion around, like New York County had all of those extra events that we found really hard to really match their uptake. But a number of the counties actually had quite a bit of an agreement. So I think we're a lot more confident in some of our baseline estimates than we were before. But most of that is just because we have so much more data now. We know we have better ideas of when behavioral adaptations occurred. We know the vaccine timing a little bit better. Let's see. Yeah, I always want Patrick on these calls because this was his project and all everyone wants to talk about is the Reddit calibration. I think there's, I think the bigger question about risk perception is a really good one. It's hard to know if, I think, so we could say it's not just like the Reddit posts, he did a little bit of I think he did a little bit of qualitative analysis. To see what people were saying, and it looked like people were recommending similar reductions in one-time partnerships. We also know from contacts who do outreach with Grindr and other apps, similar to how they had, you could put your vaccination status for COVID on, you could also put your vaccination status for Mpox. And so we know that there was potentially some shift in behavior or how you chose a partner based on that, which that we didn't really capture in the model. But in our model, because the way that other survey data was asked about what types, or the survey data asked what kinds of behaviors you were changing. And so most people said that or a lot of people said that they were reducing total numbers, but in particular, new partners. So a little bit like in COVID, where you're okay, I have these set of 5 people there in my bubble, I can have repeated contacts with them, and it's going to provide some level of safety. People in this outbreak were continuing to have contacts with their existing partners, but reduce the number of new partners. So we had translated that into reductions in the one-time spontaneous network. It's not perfect, but that was kind of the clearest way that we could address that. Yeah. Using reported cases as behavior. It actually ends up the way that particularly because in DC, the like peak of cases is around the peak of uh, the like Reddit posting. Those two things, they're actually very similar. Like if you had done it like that too. I think that is how we initially had done it, had linked it to like local burden. But we had gotten some feedback from other people who wanted us to try and link it to basically something else and not just use local burden as our metric. And so that's why he did all of that work around both Reddit and Google and other things. The reality is that particularly in DC, because the like timing of the outbreak and the peak kind of mirrored larger national trends, those two things end up being very, very similar. I think it might have been different for other places, but for this model, I think it was a little less important. Is that Nicholas?
Thanks, Emily. I was just wondering what you're planning to do to update for Clade 1. Like, will you be looking at different transmissibility scenarios? And if so, how do you think you'll ground those? Or is it just going to be severity, or what's your approach going to be there?
Yeah, so at the moment, it's almost exclusively an increased probability of transmission per contact. And that it's hard to ground that in any real observed data. Most of the data, when you're looking at either severity or secondary attack rate or even like viral load, is looking at the strains that were more traditionally like household, like zoonotic transmission. So very few studies are actually looking at the difference between this clade 2B, the sexual transmission strain, and others. And, we don't have updated data for the way that clade 1 might have changed in order to be more transmissible via sexual transmission. We know from some studies, like there's a mouse study that was looking at viral load, and it had ranked it from clade 1 to clade 2 to clade 2B. And so we know from like other studies that the viral load is less intense, but it seems like the duration of infection, like the duration of rashes, is actually fairly similar. So there was only like a few different ways that we could kind of, distinguish between the clades. And a lot of it is kind of just, I'm not going to say guesswork, but there's not a lot of hard data to go on. And yeah, it's more severe, so it has a higher mortality rate. I think partially because the rash is more severe, but it's also like the vast majority of mortality from clade 1 is among kids, and so I'm not sure if that's like a kid specific severity, and like if it was just in adults, you wouldn't see this like if in the sexual transmission context, I'm not sure we're going to see like the same increase in mortality we do from traditional clade 1 to clade 2. Yeah, so most of the deaths from clade 1 are among like kids who have gotten either zoonotically or through household transmission, and we're less worried about that in this context. Yeah. I think Chris was next.
Cool, thanks. Yeah, thanks for the talk. My question's about the network structure. So I like that you've used an ERGM so you can, get your individuals to interact and have decent assortativity based on behavior. In terms of the actual network you've got, have you looked at any of the assortativity in that network? So in particular between contact numbers. So in the issue in the UK, we had loads of sexual health surveys where we asked people how many sexual contacts they had, so we knew the distribution of sexual contacts, but we had no data on the assortativity of those. So you could build a network where all of those 100 contact people interact with 101 contact people, or they could all just form one cluster. I think it's likely to be the latter, but we have no data to inform it, which put me off doing anything network based in the UK. It'd be interesting to see what your thoughts are.
Yeah, so we don't have any of the I think that if I dug into the data, there might be some questions about do you know if your partners have partners, right? So that would kind of get at that assortativity question. Yeah, right now it's just set up that people have higher activity. And so, yes, they're more likely to contact other people with higher activity, but it's just because they have higher activity. It's not like an additional assortativity, right? So if you just looked at who was mixing with who, you would see the high activity group more frequently mixing with the high activity group, but it's not because they're preferring that, it's just because that's who's active, right? So you would like observe that, but I do think it's unclear a little bit. As we do have like people who have different risk groups, so it's just like the frequency at which they have one-time contacts is different. So I think that gets at it a little bit, but yeah, as like a generative process, we don't have a term in the model to say like this is the extra level of assortativity for like if you're like trying to pick other high node people. I'm not sure people actually do that. But it would be interesting to try and like go back and figure out if we can kind of get a metric of that.
Yeah, I mean, my thoughts were, so it's if you've got loads of transmission at say saunas and dark rooms and chemsex parties, the individuals going to them are all going to be high contact. You're not going to have one really high contact person and then loads of people who. I mean, you'll get some people who experiment and will do it, but you expect it to be skewed completely the other way, which means that you're not getting this random sort of attachment.
Yeah, no, that actually brings up a really good point, because one of the things that we have been thinking about how to incorporate is we know a lot of like transmissions happened at events, like, and not just like at Pride events, but like events surrounding those events, so like after parties, chemsex stuff, group events, like group sex. And we don't really, in this framework, don't currently have a way to explicitly model that, but I would like to. So like one of my longer term projects is to try and go back into the data and see if I can build a like an additional network that's solely just events. So you have like your regular kind of contacts, and then you can control a little bit more about like the frequency of group events or like intensity of events around certain other like events that happen in the year. I'm using the word events too much, but I think you get what I mean. But because I do think that is something, especially for this population, that we're missing. So yes, I agree basically.
It'd be interesting to see what if you manage to succeed again that way.
When Sam asked me to give this talk like 5 months ago, I was gonna try to put that network together by then, and then this MPOX 2024 response happened, and that's been put by the wayside. But it's still on the list. Yeah. Sam, do you have another question?
I do. Mine is, it's again a bit of a pedantic one. So you said you depended a lot on the natural history parameters and those being estimated by another team. I imagine you've since aware of the work that Kelly and other people have done on how those were biased. How much of a problem would that be? So the kind of amount of bias you would expect is like 1 to 5 days or something, and you had like a delay with like a mean distribution like of 5, something like that. If you had that in a couple of your parameters, what sort of implications would that have for your results?
Yeah, that's a good question. I think so. In the initial paper, it wouldn't have necessarily made a lot because it was very, hi Caitlin, preliminary, and we also didn't have that like extra class of asymptomatic people who are asymptomatic but they're infectious. I think that certainly it would influence it a little bit more in our current models, although I actually think probably the bigger problem is that at the moment we're using and like an exponential distribution for most of these parameters, and that's probably not as accurate biologically as it could be. And so I think that's another one of the things that moving forward is considering how to kind of interpret these results with biases, but also model them a little bit more accurately. Yeah, but in particular, if you like, yeah, if we're like really wrong about the asymptomatic but infectious period, like that could really dramatically increase or decrease our estimated infections.
That makes sense. Okay. Yeah, that makes sense. This has been really great. I think we're winding down. Questions wise. So I'll just say thank you very much. And next month we have Charlotte Hammer, and then we have Etty Unwin, who's at Bristol and did a lot of the Imperial response work. And then in August, we have Finlay Campbell, who is at the WHO Pandemic Response Centre. So there's some good people coming up. But then after that, we have quite a gap. So if anyone has any thoughts of people who could come and speak, that'd be really great. Yeah, so yeah, I think thanks very much again, Emily. That was really good, really interesting. And if anyone has any questions async, would you be okay answering them? There's like a
of course.
thread on the Epinarcast community site that people can post questions in, or yeah, or email.
Yeah, so I put my email in. I'll try and look at the